Good evening, sir. Good evening,
Good
sir.
evening, Rama. Good evening, Krishna.
Good evening, sir.
And good evening, Shobi.
Good evening, sir. Good evening, sir.
Good evening, Shobi. Murali,
Sir,
we'll wait for some more time.
yes, sir. We can wait for another 2 to 3 minutes, sir. Then we can start the meeting.
I think we can start, Murali,
Okay, sir. Sure, sir.
because those who are joining, let them join. So, good evening, all the consultants from Sri Ramakrishna Hospital and from outside the hospital, and practitioners from the city of Coimbatore who have joined this webinar, which is conducted monthly for the last 2 years by the Sri Ramakrishna Hospital Management, and I welcome all of you on behalf of the management of Sri Ramakrishna Hospital. And I welcome Dr. G. Krishna Shankar, consultant in diabetes, thyroid, and endocrinology, who is going to talk about difficult diabetes. Actually, the topic itself has kindled some interest in me, and whether the diabetes itself is a difficult disease or it produces many difficult problems to settle, or is it difficult to control the diabetes? And so many questions rise in me, and he's going to talk about that topic, difficult diabetes. And he is a senior consultant in diabetes endocrinology in Ramakrishna Hospital. And he has picked up his practice tremendously, and he is doing very good. And the other speaker is Dr. Shobhi Anandi, our consultant pediatrician and pediatric endocrinology. Actually, her specialty is only a difficult specialty. Pediatric endocrinology is very difficult to pick up, and probably they'll have less number of patients. And I mean, recognition and awareness among the public is still to pick up. And she is at an young age, she has become chosen a very difficult specialty. And she has joined Ramakrishna Hospital a few years back, and she is also now doing well. And after joining as a general pediatrician also, and now she is busy in her practice in the hospital. And she is going to talk about the facets of pediatric endocrinology, which is really an interesting topic. I also would like to know about the facts and facets of the pediatric endocrinology, because many of us, even doctors, we may not know about that specialty so much. And I welcome both of them on behalf of the management, and I thank them for accepting our invitation to talk today for the benefit of all the consultants and the practitioners in and around Coimbatore. And now I welcome Dr. G. Krishna Shankar.
So thank you, Dean sir, for the kind introduction. And at the outset, I would like to thank the management, administration, staff of Ramakrishna Hospital, Ramakrishna Trust. So I will consider this an honor since whatever I am going to discuss now has taught me a lot, has most important helped the patients. Since we all know diabetes is the most major challenge. Even it is the most major challenge in even the COVID era. It is going to be a challenge forever. So all these cases which I present. So all these cases, I'm going to present only a few case capsules which we encountered in our hospital and how to bring about the solutions. So, difficult diabetes in the sense patients who presented with challenges in not just alone glycemic control. The glycemic control, not a mere number. The existing pathology, the coexisting pathology itself was exacerbated by the diabetes difficulty in controlling the diabetes and hyperglycemia, and it got attenuated, got better after overcoming the challenge. So what were the steps? So every patient is personalized. We all know that's the core of medicine. Although we have guidelines and go according to textbooks, ultimately it deviates. So there comes the role of teamwork, where the entire hospital, all the consultants, the staff, the juniors, everybody comes into play, where we finally eventually help the patient. So the motto is never stop learning because it keeps on teaching, particularly the art of the state of medicine, the art of medicine. We are always students. So here is one patient, almost like 2 to 3 years back. This patient came, a 50-year-old female with 20 years of diabetes mellitus. She was at presentation. She was cachectic, had a coronary disease, recurrent urosepsis, chronic urinary infection, proximal myopathy, proliferative diabetic retinopathy. Almost all, eventually, all the complications of diabetes mellitus. You wonder everything she has except next step is death. So before that, it's like a copybook stuff. Everything in the textbook, everything, whatever is microvascular complications, macrovascular complications, acute complications, everything she had. Proximal myopathy, severe proliferative diabetic retinopathy. So 10 years of diabetes, HbA1c still in 9 to 12. So what is the lesson is, as soon as you find diabetes mellitus, be it type 1 or type 2 or type 3 diabetes, whatever you find, diabetes due to drugs or pancreatic disease, so try to maintain the HbA1c less than 8 as soon as you diagnose and hold there. Do not allow it to increase throughout life. So you are almost all these complications are preventable. So fortunately for this lady, still the creatinine is holding good. The only thing is renal failure, which is pending for her. So she was on essentially twice daily of NPH insulin of 10 units plus regular insulin plus glimepiride plus voglibose of 0.3 milligram twice a day. So another thing is a concept of adding more and more, keep on adding more and more medications. So once a patient starts getting complex and getting complicated, so it will be wise and wise to bring down oral antidiabetic agents, except a few drugs like gliptins, and maintain on insulin alone. So this patient, so what we did was we put on ultra long-acting analog insulins. So once plus 3 times of short-acting insulins, plus only a gliptin. So the major thing is try to switch over to the modern insulins if they are affordable. So in this patient, our team, we discuss with them, tell them the cost effectiveness of each and every insulin. Almost all the insulins are available in the hospital. So this patient would benefit from these kind of modern analog insulins, because the something called as glycemic variability, which is less in this analog insulins, and put on only something called as gliptins, oral antidiabetic agents. We have 4 types of drugs. One is metformin, another is gliptins, sulfonylureas, and SGLT inhibitors. So this patient will benefit from gliptins alone, since no other antidiabetic agent is going to work for them. It is going to cause more harm. So we started titration, but the patient lost to follow-up. So incidentally, what's happening? See, she shifted to North America. She suffered a renal papillary necrosis again due to diabetes. Admitted elsewhere, I think in Canada. She was in critical care unit. DJ stenting was done. IV antibiotics. She came back to us. Again, got admitted voluntarily. Why? The reason you would wonder how we are so cost effective. There, incidentally, the patient did not have an insurance. She was not a Canadian citizen. She is a citizen. She didn't have insurance. She had an emergency admission that they will cover it. Thereafter, a long admission in the hospital. You won't believe her bill was around, say, 40 to 50 lakh Indian rupees. There she spent for near 8 to 9 days, simply because she didn't have insurance, neither in the public sector nor in the private sector in Canada. She was not a citizen until then. So she came here, then she started praising, in spite of her misery and suffering, she started praising our system, that how cost effective we are. So she voluntarily got admitted. She wanted to control everything, solve everything, and go back. So some of the HbA1c for this individual was 8.1. Why in this case is this a good sugar control? No, this patient has lost a lot of weight. So even losing a weight because of critical care admission, a patient lose a loss of visceral obesity, that tends to bring down the HbA1c also. So cachexia basically. So that was that patient. So what happened is this patient had a glucose level, look at a glucose profile, a fasting of 245, post breakfast of 400 plus, post lunch was low, post dinner was 214. So this also shows the importance of long 24-hour monitoring, not just fasting, or not just after breakfast, or not just evening sugar. So look at this individual, how you can see the variations, post breakfast being the highest. If we don't check the post breakfast, we tend to miss it. Then that HbA1c gets escalated, skewed to the right side, upper side, so then bound to complications. So this patient required a long-acting insulin and only a short-acting insulin in the morning. So you did not control the post-lunch or the pre-dinner or the post-dinner. Only the post-breakfast needs to be controlled. She required a short-acting in the morning alone. So this is how titration goes. It's not initially you have to start with the insulin, say BD or premix, whatever, but then you have to titrate according to each and every individual. So this candidate, see eventually after adding other drugs, how the fasting came down post breakfast, post lunch, and post dinner. It's streamlined. So next patient, she's 60-year-old female. She had a renal cell carcinoma in the past, say 5 to 8 years back. Had a nephrectomy. Then incidentally, she developed after a year or so pancreatic metastasis. So total pancreatectomy, radical surgeries were done by the gastro department, and obviously they have become insulopenic after total pancreatectomy. It was a massive radical surgery. So she was put on basal bolus insulin, something like a type 1 diabetes. You have to treat like a type 1 diabetes. But there's a difference. All pancreatomized patients are not like type 1 diabetes. They do not have a glucagon response. So the amount of insulin required for them will be very, very low and have extreme glycemic fluctuations. Even type 1 diabetes have that, but you won't believe their unit requirements like 3 units, 5 units, that's all. Unlike in type 1 diabetes, sometimes it may vary because you have a minimal glucagon response. Here, even glucagon is absent for them. So the patient did reasonably well. Then, since the metastasis for renal cell carcinoma, she was started on sunitinib. That's the modern tyrosine kinase inhibitors and monoclonal antibodies for malignancies, modern novel agents. But incidentally, the patient developed severe hypoglycemia every 4 to 6 hours. So, incidentally, what happened is the treating physician thought that it's because of insulin, obviously because of insulin. So they stopped insulin, but you cannot stop insulin. Patient doesn't have a pancreas. So what happens is insulin dosage was reduced and stopped, but obviously it is going to escalate. So this patient was on basal bolus insulin, but still there was high glycemic variability. So this is the pattern for the individual. So initially in the mornings she will always go for hypoglycemia, always in hypoglycemic range mornings, whereas in the daytime it's fine or high. So what's essentially happening is the impact of sunitinib treatment on blood glucose levels in patients with renal cell carcinoma. This is becoming a huge problem across the globe. So the novel tyrosine kinase inhibitors and other drugs are causing endocrine problems, which are slowly we are coming to know about. Much like in COVID, only after a year we have started realizing about various hormone disorders like thyroiditis as well as new onset diabetes in COVID. COVID causing cortisol insufficiency, all are being reported. I have started personally seeing a lot of patients presenting with cortisol insufficiency alone. See, after 8 months of COVID, not just because of the steroid use. So patients are started getting these hormones the same way. Patients being treated on tyrosine kinase inhibitors for malignancies are also getting a lot of thyroid disturbances and diabetes, new onset diabetes, as well as hypoglycemia. So this patient, essentially what's happening is, she's having early morning hypoglycemia. Simple, we stop the basal insulin. We just give a bolus insulin. So actually the solution is quite simple. We have to understand the pathology and the concept of why it occurred for the patient. So at least the patient was able to sleep without fear of hypoglycemia. The patient came to our hospital mainly not to control the glucose, because they were literally, she didn't sleep continuously. She didn't have a continuous sleep beyond 2 hours for the past 2 years. She wanted to get rid of hypoglycemia, but also to treat the diabetes. That's what she wanted. They didn't want a HbA1c of 7.3. They just want to live comfortably. That's what the patients with sometimes malignancy things. So that's what we are as doctors, we are bound to give them. So actually, I have made what you might wonder. This pattern is abnormal, and this pattern is normal. Actually, it's vice versa. This pattern is normal, appears normal, but for the patient, this is hypoglycemia in the morning. So this pattern, the patient was living comfortably, no hypoglycemia at all. But the glucose level almost like literally say 10, not in the range of 500 or 600, at least 350. So according to the patient, we have to treat. It's not always numbers. That's what matters. It's not always numbers. So fasting is normal, PP is not like that. Patient's quality of life, that's what in a hospital we provide. That's the most important thing. So another individual, type 2 diabetes, peripheral artery disease, below-knee amputation done with kidney injury, creatinine of 2. So incidentally, Another concept is all renal dysfunction, be it AKI or chronic kidney disease in diabetes mellitus, even uncontrolled diabetes mellitus, need not be essential to diabetic kidney disease. Patient have a combined concept, a combined pathology of non-diabetic kidney disease also. So that's what being worked up in the nephrology department of nephrology. So there they found out that patient also had a non-diabetic kidney disease requiring immunosuppression. The patient was put on steroids 40 milligram and again tapering dosage. So basically we are adding fuel to fire. So we are adding prednisolone to a patient with diabetes mellitus. It goes sky high. Particularly another concept is post meal. So always don't target, if you put on steroids, don't always target the fasting and the post breakfast. What's going to rise is predominantly post lunch and post dinner. So look at this individual, how the regular insulin, requirement of regular insulin, 28 units in the morning, 42 in the lunch and 46 in the dinner. So supposing if you don't check the dinner, post dinner glucose, we are bound to miss the glucose level 430 in the night. HbA1c is going to high. Patient might improve from immunosuppression, but will deteriorate with diabetes. So that also we need to target. And the creatinine got stabilized. The nephrologist brought down the steroid dosage. So now the insulin dosage is low, but the patient is going reasonably well. So another individual with HbA1c of 12, premixed insulin with recurrent hypoglycemias. So this patient was put on basal bolus insulin, but not willing for 4 pricks of insulin. So this patient was put on human insulins of split mix. So it's not always like we can basically this talk itself is for personalization. Not always like say some patients may not be affordable for basal bolus insulin. Giving a glargine insulin or spending 600, 700 per day, and sometimes short-acting insulins, they may not be able to afford. You can even use regular and NPH insulins, which are relatively cheaper, and mix them. That's called split mix. So this individual, see, just to show that how titration helps. Say in the upper zone, if you see the sugars are quite high, 500, 300, 400 plus, etc. And if on the right column, if you see, that is the amount of insulin that individual required. The upper column is say 32, 16, 22. So that is the regular insulin, short-acting insulin, plus the NPH insulin, again very high, 20, 16, 18. So how we reach this number, we started with a very low dose and we titrate, then check the glucose, accordingly we titrate. So eventually this individual required 60, 12, 26, so much of units of regular insulin and 12, 18, 14 of NPH insulin. Per day almost 140 units. So, and remember, sky is the limit for insulin. We always tend to have a thinking that no, this is very high dose is insulin. There is no upper limit of insulin or lower limit of insulin. We can just stop or use whatever amount we want. There is no basically harm of insulin. The only thing is persons may go for weight gain. So this individual, eventually, this was the dose we reached to bring down the glucose to less than HbA1c less than 7. She started developing hypoglycemias. So that's good. At that point, it is bad, but in general, it's good for her. We started down titrating the insulin dosage and started adding other oral antidiabetic agents apart from sulfonylureas. So, upon adding all the existing available oral antidiabetic agents, her insulin dosage started coming down. And we were able to bring down and stop insulin for her. Sorry, I didn't put that slide. We were able to stop insulin for her. Another lesson is it's not always when you require a high dosage of insulin, doesn't mean that patient should be always on insulin for life. So modern other antidiabetic agents can be utilized and insulin requirements can be brought down. So this is a post-CABG individual HbA1c of 13 and the patient was on mixed insulins of 30-70. Again, recurrent hypoglycemias. Anyway, the patient went for CABG. So at that time, insulin infusion was used as per cardiovascular protocol. And post-operatively, patient was put on mixed 50 insulin of TDS. Again, early morning hypoglycemias, but postprandial hyperglycemias. So again, what we did was we stopped basal insulin or long-acting insulin. So this is nothing but exaggerated Somogyi phenomena. The patient has got a very exaggerated Somogyi as well as Down phenomena. So very low fasting sugars, but very high post-breakfast sugars. All these things occur in long-standing advanced diabetes mellitus, basically because of autonomic neuropathy. So it's not straightforward as we see in the textbook. Each and every individual, as time passes, they get autonomic neuropathy and things vary. So this patient, we put on the modern drugs called as SGLT inhibitors, we call as flozins. So just to encounter the post-breakfast hyperglycemia, we stop the basal insulins and no hypos in the morning. So this, if you see the continuous glucose monitoring chart, severe hyperglycemias for this individual. So going erratically up and down. So this is basically nothing but a 9-month child with a HbA1c of 9. So genetic testing was subject of neonatal diabetes. So what is relevant here is for children, particularly very young children, Shobhi will also cover that, very young children, it's not always you have to bring down exactly to 143 of fasting glucose and a postprandial of 193. So what's the most important point is because their variability will be very high. Do not get panicked or alarmed. The most important point is just put some insulin and prevent ketoacidosis for them. So this patient was put on very, very low dose of insulin. That's all they need. So right. So this case is a elderly lady with a fracture of spine stable. HbA1c was normal, but slowly the glucose started rising. So we were wondering, we were using tons of insulin for her, Glargine of 42, regular insulin of say 100 units per day, plus drugs. Still, the glucose started escalating. So eventually, what we found out was the technique of insulin. So we used to teach almost every patient. Still, the patient for almost 6 months was using a subdermal injection rather than a subcutaneous injection for insulin. So this was the error. This was rectified and given subcutaneous injection. So again, another young guy, 11-year-old female, for 7 times patient was admitted for DKA, but still they were compliant with large and regular insulin. Still the HbA1c was high. Why? The storage. The patient and the patient family member, they have stored the insulin in the freezer, not in the fridge. They are stored in the freezer. So another common error, we have to teach that also. We cannot just take ourselves for granted that they will be knowing if we teach them. You have to tell them specifically it's in the fridge door, not in the freezer. So obviously the potency will come down. So I will have to finish this case. So another lady for referred for type 2 diabetes, newly detected, HbA1c was 8, but hypertensive, back pain, proximal myopathy, hypokalemia, but the sugars were 500. So what's happening? HbA1c is only 8, correspondingly it's barely say 250 or 200. Still the sugars were going sky high, then you have to suspect something. So something is driving the incidental high glucose level, the commonest being the opposite of insulin, that is cortisol. This patient had got endogenous hypercortisolism, that is Cushing's syndrome. So eventually we found out it was a Cushing disease, ACTH secreting Cushing disease. Patient refused surgery in spite of explaining, but the patient recovered with good oral medical management like ketoconazole, etc. She is doing well. So I would like to stop it here. So just one more point. So just to the most important, again, other common error is the difference between 100 per ml and 40 per ml syringe and vial. This common error occurs. Sometimes patient might be getting a 100 per ml vial with the red color syringe, that is the 40 per ml syringe. This will also cause erratic hyperglycemia and hypoglycemia. So every time we have to work as a team in our hospital. We do it. So every time you should be alert that every vial and syringe have corresponding same units of per ml. So I would like to stop it here for paucity of time. Thank you very much. Thank you.
Good evening.
Thank you, Dr. Krishna Shankar. Now I request Dr. Shobhi.
A very good day to one and all present here, and thank you, sir. Thank you, sir, for the introduction. And at the beginning, I would like to thank the hospital management for giving me this opportunity. So today I'll be talking about a few interesting cases in pediatric endocrinology. As we all know that among the pediatric endocrine disorders, it is pediatric diabetes and obesity which receives maximum attention. And as Dean sir rightly pointed out, there are other pediatric endocrine disorders which can be easily picked up in our day-to-day practice. So I just want you to, I just want to share such case scenarios with a brief introduction saying that endocrine disorders in children are quite different from their adult counterparts, right from the etiopathogenesis, the clinical presentation, the lab cutoff values, and finally the treatment protocols. They also have various clinical presentations which could be easily mistaken for other common conditions. Growth, development milestones, and puberty are unique to the pediatric population, and we must take it into account when we are managing a child. Early diagnosis and effective treatment often leads to normal growth and development, and it's very rewarding to see the child growing and developing normally in front of you. So basically, to drive home these points, I would take you through a few interesting case scenarios. So this was a 2-year, 5-month-old female child who was symptomatic since she was 1 year of age. She had deformity of legs and progressive difficulty in walking. She was unable to walk since the last 5 months. There was lower limb pain, and she had history of multiple convulsions at 1.5 years of age. At that time, she was diagnosed to have hypocalcemia with carpopedal spasms. And mother reported having such similar episodes when the child used to cry excessively. There was no other positive history of renal or hepatic disease, no history suggestive of malabsorption, polyuria, and no fractures. And this child was the first child of non-consanguineous marriage. She had a younger male sibling who was absolutely normal. Her birth and development was absolutely okay. Family history on probing, there was mild bowing of limbs in the paternal grandfather, and father had history of convulsions. Details was not available because he was abroad. This is the anthropometry of the child. Her weight is just on the minus third standard deviation. Height is well below minus 3 standard deviations, and head circumference was normal. This child on examination was irritable. She had florid signs of rickets. If you see, there was frontoparietal bossing. She had enamel hypoplasia, wrist widening. She had bilateral genovarum, ankle widening, and double mellitus. There was no organomegaly. There was no icterus. So this picture actually shows the wrist widening and it shows the genovarum very clearly. You can also make out the ankle widening here. These were the x-rays which she brought from outside. So she had already been investigated outside, and the x-rays shows florid signs of rickets. In fact, it's the textbook picture. So we had this widening and cupping and splaying and fraying of the metaphysis and the genovarum, which can be seen on this film. Outside reports had a normal vitamin D value, low calcium, normal phosphorus, and high alkaline phosphatase. So what we do in routine scenario is we just give supplements with oral vitamin D and calcium. After 3 months, the reports remained more or less same. In fact, the calcium did not increase at all. Phosphorus had started dropping, and alkaline phosphatase started increasing. So the dose of oral vitamin D and calcium was increased. The next report after 3 months actually showed a high normal vitamin D, but calcium and phosphorus were low, and alkaline phosphatase was very high. So vitamin D supplementation was stopped, and it was at this time this child was referred to us. So over this period of 6 months, the child who was walking had stopped walking. So this is what a significant clinical change which had taken place. This child presented to us after 3 months, and the investigations done from our side confirmed high normal vitamin D levels, hypocalcemia, hypophosphatemia, high alkaline phosphatase, magnesium levels were normal, renal function test, liver function test, electrolytes, especially bicarb, was normal. Her ultrasound abdomen showed normal kidneys. There was no nephrocalcinosis. Spot calcium create ratio, which is usually done to measure the levels of calcium excretion in the urine, was low. So it was not hypercalciuria. Her intact parathyroid hormone levels was 350, which was very high. Now, normally what happens is when we have low calcium levels in the body, it triggers and stimulates the PTH secretion. This is secondary hyperparathyroidism in an attempt to bring back the calcium levels to normal, which was not happening in this case. And finally, we got the serum 125 dihydroxy vitamin D, which is the active form of vitamin D, and the levels were low. So normally what happens in our body is that vitamin D gets converted to the active form of vitamin D for action. So in this child who had high levels of vitamin D and low levels of active form of vitamin D, this is vitamin D dependent rickets type 1A. And this can be easily treated by giving directly the activated form of vitamin D. So if we just go through the physiology of vitamin D deficiency rickets quickly, it is either due to decreased skin synthesis because of decreased exposure to sunlight or because of dark pigmentation of the skin. because of maternal vitamin D deficiency, who passes on less vitamin D to her baby, malabsorptive disorders, obesity, where vitamin D gets deposited in the fat tissues and you have low levels of vitamin D circulating, any hepatic or renal dysfunction which interferes with the metabolism of vitamin D, and then genetic causes, wherein we could have deficiency of 25-hydroxylase enzyme, which is important for the formation of 25-hydroxy vitamin D. This genetic defect is called vitamin D dependent rickets type 1B, or there could be a defect in 1-alpha-hydroxylase enzyme. This is known as vitamin D dependent rickets type 1A. This is what our patient had. So the conversion of 25-hydroxy vitamin D to 125-hydroxy vitamin D was defective. Vitamin D deficiency could also result because of deficiency in or resistance at the site of the receptor. This could give rise to VDDR type 2A, or there could be abnormality in the response element in the DNA, which could give rise to VDDR type 2B. So if you know the cause, we are able to treat. So this child was treated with activated vitamin D and calcium supplements, and within a month the calcium levels were normal, alkaline phosphatase had dropped, and what was surprising is the child had started walking. So within a month, so it was very rewarding to see the child walking. So vitamin D dependent rickets is actually because of loss of function mutation, which codes for 1-alpha hydroxylase enzyme, which converts vitamin D to activated vitamin D, that is calcitriol. It's an autosomal recessive condition characterized by bone deformities, growth retardation, muscle weakness, delayed motor milestones, and hypercalcemia. So everything was present in our patient, and presents with hypocalcemia, hypophosphatemia, hyperphosphatasemia, high PTH, normal calcidiol, and low calcitriol levels. So what we have learned from this case is that though vitamin D deficiency is the most common cause of rickets and responds to vitamin D supplementation very easily, when there is a poor response to vitamin D, we should do investigations to rule out any other underlying cause. So you should keep genetic causes in mind. Early diagnosis and prompt intervention can prevent deformities. The second case is of a 7-year, 9-month-old female child who presented with history of menarche. So this was a precocious puberty. She was the first child of non-consanguineous marriage, otherwise absolutely normal till date. Normally when there's a precocious puberty case, we often ask for growth spurt. So when I asked for that history, there was history of weight gain since the last 2 years, but the child had not grown. In fact, the younger sibling had become taller, and there was history of poor appetite and constipation. If you look at her anthropometry on growth chart, her height was way below the 3rd centile, way below her target height, and her weight was normal. So she had short stature. She looked dull and lethargic. She had dry skin, delayed relaxation of reflexes. There was no goiter. There was pallor, and she had not lost any of her primary tooth. And she was 7 years, 9 months. By 6 years, you're supposed to have some shedding of the primary teeth. There was bradycardia, which was around 60 to 70, and her Tanner staging showed absent axillary pubic hair and Tanner vestige of stage 3. So this child had some features of precocious puberty along with a lot of features of hypothyroidism along with short stature. So she had also brought an ultrasound. Basically, she was referred for this ultrasound report. So this ultrasound showed bilateral ovarian cysts, where right ovary had a cyst of 2 centimeters and left ovary had a cyst of 1 centimeter. And when I got the bone age done, the bone age was 5 years. So normally in a case of precocious puberty, we expect an advanced bone age. There will be a tall stature and advanced bone age. So here there was short stature or growth arrest, and the bone age was delayed. So as expected, the child had hypothyroidism. TSH was more than 100, free T4 was low, and the cause was autoimmune because anti-TPO antibodies were positive. So this is a case of pseudo-precocious puberty due to severe untreated acquired hypothyroidism. So thyroxine replacement is only therapy. So at 1 month follow-up, the child had 1 withdrawal bleed. She had lost weight. Her activity had got better. In fact, even 2 primary teeth had fallen off. She was very happy because of that. Her investigations showed a normalization of the thyroid function test. At 3 months, there was no menses, and her ultrasound had showed resolution of the cyst. And this was the child who, and she's been regularly following up over the last 2.5 years. And if you see her growth chart, see, she's grown beautifully. She was at this level, and now she's almost grown up all the way, reaching her target centiles. She has grown at the rate of 10.8 centimeters per year. So this is known as a one-way Grumbach syndrome, which is isosexual precocious puberty, and ovarian cyst, which is associated with long-standing prepubertal hypothyroidism. Growth arrest and delayed bone age differentiates it from other causes of precocious puberty, because normally in precocious puberty we have a growth spurt and advanced bone age. What is the reason for this? Is supposed to be elevated or high TSH levels, which cross-react and stimulate ovarian FSH receptors because the TSH and FSH, they share a common alpha subunit. Signs of pubertal development and ovarian cysts regress with thyroxine therapy alone. You need not do anything else. So the key points from this case is that untreated acquired hypothyroidism is usually well tolerated. So usually don't have much of signs and symptoms initially. It is detected only when growth failure occurs, which can be diagnosed only if the growth of the child is plotted on a growth chart, like what we've just seen in the previous slides. Normally, hypothyroidism causes delayed puberty, but in this case, there was precocious puberty. This is known as Van Wyck-Grumbach syndrome, and we need to be aware of this because we want to avoid unnecessary evaluation and surgical interventions for the ovarian cyst. It will resolve with thyroxine itself. So, early and effective treatment with thyroxine reverses the symptoms and promotes growth. The third case is of a 15-year-old female who came with primary amenorrhea. Now, she was diagnosed already with delayed puberty due to acquired hypothyroidism outside. She was on thyroxine supplements, and for some reason, she had stopped it over the last 2 to 3 months. Otherwise, absolutely normal till date. And if you look at her growth chart, her height is here, way below the third centile, way below her target height, and weight was normal. So there was short stature on the anthropometry. And a close examination of this child actually showed that this child had increased carrying angle. So this is increased carrying angle. She had multiple nevi over her face, and if you see, her skin was so dry. And this is the short fourth metacarpus. You can't see the fourth knuckle over here, which was confirmed by an X-ray. There was no goiter, and her Tanner staging was absent axillary pubic hair and breast development of stage 3. So she had frank signs of Turner syndrome, which was missed. So investigations showed a TSH of more than 100 with low T4. At the same time, I got an FSH and LH done, which was high. Estradiol was low, confirming hypergonadotrophic hypogonadism. Prolactin was normal. USG showed a small uterus and a small ovaries also. So there was acquired hypothyroidism, hypergonadotrophic hypogonadism in a child who presented with stigmata of Turner syndrome. So the next step would be definitely to get the karyotyping done, and the karyotyping showed absence of deletion of short arm of one of the X chromosomes. This was a variant Turner syndrome. So Turner syndrome is a chromosomal disorder where there is a partial or complete monosomy of the X chromosome, and if you see, you could have various forms in which it could present. It should be considered in any short girl, irrespective of the presence or absence of pubertal signs. Now, why is it important? Because they could have associated endocrine problems requiring treatment for puberty induction and maintenance, treatment of the associated hypothyroidism, monitoring for diabetes mellitus, and non-endocrine issues like, they could have cardiac anomalies, they could have renal anomalies, celiac disease, and scholastic performance. So all this has to be diagnosed and accordingly intervened, and that is possible only if we consider the diagnosis of Turner syndrome. So the key points from this case was basically that Turner syndrome should be considered in all children, in all short girls, irrespective of the presence or absence of pubertal signs. The diagnosis helps not only in further management, it also helps in future monitoring. So we have monitoring, the monitoring parameters that a Turner's child should be monitored in so and so way so that the child will get benefited. So you should always look out for subtle clinical clues. So all Turner syndrome don't come with a textbook picture of webbed neck and all those other things. They basically could have even minor subtle clinical features which should be picked up on clinical examination. And it's very important to understand the role of growth charts. If you're plotting the growth of a child, a Turner's child grows well up to 4 to 5 years of age and then starts faltering on the growth. And then this is picked up, then you can diagnose Turner's earlier. And the last case scenario is about a 3-year, 7-month-old male child who was a known case of atrial septal defect, had undergone device closure 6 months back, waited for growth, and then was referred for failure to thrive because he was not growing in spite of the ASD being closed. So his development was otherwise normal, and when he came, his height and weight both below the third centile, but height was more affected than the weight. And so we just thought we'll give him some time. We got his blood counts, his ESR, thyroid test, renal function test, they were all absolutely normal. So just diet advice was given, growth monitoring was advised. And then when the child followed up actually regularly every 6 months for the height and weight, and at the end of 1.5 years, so when he came back, he had actually, his weight was good. He had actually picked up around 2.5 kgs and he touched the third centile, but the height continued to be low. So the height was still more affected than weight, and this is the time we decided to intervene. So this child, this is at 5 years of age. He had no dysmorphism, but he had an infantile face. This is not the face of a 5-year-old child. He looks too young for a 5-year-old child. There is no midline defects, no goiter. He is genitals prepubertal, normal volume test is no micropenis, and systemic examination was absolutely normal. His bone age was only 2.5 years, at 5 years of age. So there was significant bone age delay, and his thyroids and cortisol levels were absolutely normal. MRI brain to see for the size of pituitary was normal. The posterior pituitary bright spot was seen, and infundibulum was normal. So finally, he actually had to, with the parameter of short stature with delayed bone age and other hormones normal, he took a for a GH stimulation test, which was done with the help of clonidine. And surprisingly, his highest or peak GH level was at 60 minutes was only 4. So anything less than 7 is considered to be GH deficiency. So you should have at least one value more than 7 to rule out GH or growth hormone deficiency. His IGF-1 values were also low. It was at -2 standard deviation. So this was a case of severe growth hormone deficiency, who was treated with recombinant growth hormone at 30 microgram per kg per day. And if you see his growth chart, so this was the growth chart when we were following him up for the first 18 months, so from 3.5 years to 5 years. And this is how his weight was, his height was, and this is how his weight was. And at 5 years, the growth chart changes because you get the other growth chart. So here, at 5 years, we started growth hormone, and then you can see how the growth has actually picked up. And he has now almost reached his target centiles, which is here. The target centile is here, so he's almost growing at par. And this child grew at the rate of 10.5 centimeters per year. And you see, this was the child when we started growth hormone, and at 2 years, he is now a tall boy. So isolated growth hormone deficiency could be congenital, which is usually genetic causes, or it could be acquired due to trauma, tumors, or radiation. Craniopharyngioma is one of the important causes. It's the commonest pituitary hormone deficiency, and growth failure is the main manifestation. Diagnosis is a combination of clinical features, oxology. Oxology is anthropometric parameters, his growth, his height, weight, and growth rate velocity, his biochemical features. So we've got the hormone levels done, pituitary imaging, and finally genetics. And once we diagnose growth hormone deficiency, we can treat a child with recombinant growth hormone at the dose of 30 to 50 microgram per kg per day, which is given in the form of daily subcutaneous injections. Adverse effects are quite rare, though we always monitor children for pseudotumor cerebri, slipped capital femoral epiphysis, or glucose intolerance. And it's important to keep monitoring the other pituitary hormones because you don't know at some point, there could be a thyroid or a cortisol deficiency. So the key points which we learned from this case is that growth failure could be due to innumerable causes. So we could have multiple reasons. The role of growth chart in this case is when we continuously plot the child's growth on a growth chart, and you realize that the height is much more affected than the weight, then you have to think of endocrine causes as the main cause for failure to thrive. Growth hormone deficiency is basically identified by serially following the child's oxological parameters and doing a thorough clinical examination. Provocative tests like the GH stimulation tests support the diagnosis. I just want to emphasize that growth hormone therapy, when used properly, is really effective and safe. But we need to continuously monitor the IGF-1 levels, the thyroid levels, and the cortisol to ensure that our doses, and we don't miss out on other pituitary hormone deficiencies. Thank you.
Thank you, Dr. Shobhi Ananthi.
Thank you, sir.
Any questions are welcome now from the audience. Any questions or opinions? Murali?
Yes, sir.
You can close the meeting.
Yes, sir.
There are no questions from the audience, I think.
Yes, sir. We can call the meeting, sir.
The topics discussed, I think all are clear. And
Thank you, doctor. Thanks for the time, sir.
Thank you, sir.
so, on behalf of the management, I thank Dr. Krishna Shankar and Dr. Shobhi Anandi for their excellent talks. And I thank all the consultants and the practitioners who have logged in for today's seminar. And I thank you once again.
Thank you, sir. Thank you, sir.
Thank you, doctor.